the youngest age that you would perform a laparoscopy on?
I would perform a laparoscopy on anybody with sufficient symptoms and to justify the procedure. If a woman is
13, say?
Oh yes, the youngest patient that I've diagnosed endometriosis in was 13. The youngest patient reported with the disease was 10 and a half years old. Age is not a pertinent factor in terms of, who do you laparoscope or who don't you. You need to focus on the symptoms and listen to the patient, not look at what year they were born.
So it's not dangerous at all to do that sort of a day surgery on?
No, it's not. It's not dangerous at all. In fact, if people really believe what is commonly said, that it's good to get in early in a disease process when it's more easily treated, then we should seek to diagnose endometriosis as early as we possibly could. The mean age of diagnosis of endometriosis in most published series has been in the late 20s.
Okay, then
29.
Why do you think that the younger women who obviously have had it for 10 years don't get diagnosed?
Women obviously have had the disease for many months or years before they actually have it diagnosed surgically. Those women go through life being told that their menstrual pain is normal for a woman, that pain in the pelvis is common, and if everybody else can put up with it, why can't you? They go so far as to tell the patient that it's all in their head. Can't you stand a little pain? You're less than a woman. Basically, the patient is put off by their family, they're put off by their friends, they're put off by their physicians who don't listen to them. And that's why the diagnosis is delayed for so long. I think that you have to be suspicious that any woman, whatever age, who's missing time from her daily and weekly activities because of pelvic pain has a disability. If a patient is missing 3 days of school a month, well, that's 3 out of 30 days. That's 10% of her time. That means if the diagnosis is delayed by 10 years in that woman, she will lose at least 1 year of her life to this disability. Now, it comes in pieces, every month, and like a leaky roof, when it's sunny, you don't worry about it. When it's leaky, you want to fix it. She forgets that she was hurting before until the next time, the next 3 days. And so it builds up to a tremendous disability in these people. They lose time from life.
I just want to add one more thing in here. There was a woman in Vancouver who is disabled up to 3 weeks out of the month. Have you seen anything like this?
I've had patients who complain of pain all month long, and the notion that endometriosis primarily hurts with the menstrual flow is obviously incorrect. And limiting himself to that type of a patient profile will cause the doctor to miss the disease in the office. He'll hear the patient's story and dismiss it as not being characteristic of endometriosis. Any pelvic pain has to be considered endometriosis until you prove it by laparoscopy to be something else.
Okay. Are there common mistakes that some surgeons make in, one, identifying endo, and 2, in the excisions endo?
The most common mistake that the surgeon makes at surgery in identifying endometriosis is looking just for the black powder burn lesion. If they look just for that, they're going to misdiagnose 2/3 of the patients, and that's going to lead to a lot of problems. In terms of removing endometriosis, excising it, many surgeons are hesitant to operate in all areas of the pelvis. They're hesitant to operate on the bowel, they're hesitant to operate on the bladder, they're hesitant to operate over the ureters, they're hesitant to operate over large blood vessels, and you need to be willing to operate in all areas of the pelvis in order to get the disease out. So this hesitancy in part has to do with lack of experience and primarily lack of experience.
Have you found endo in women who have been told they had none?
Many of the patients that I've seen have been told that they have no endometriosis. In fact, one of the patients that I have seen was told at a large Midwestern American clinic by a physician disease.
Which is, what advice or diagnosis had they been given?
It was in their head that they needed to consult a pain control center, for relief of their pain, or to consult with a psychiatrist.
Have you observed a substantial number of psychological problems in patients as a result of endo suffering?
I see quite a lot of psychological upset in the patients that I deal with. It's more due to the reaction of their family, friends, and the medical profession in failing to understand and deal with their disease effectively than it is the pain itself. The pain, of course, is very bad, and that affects them physically and mentally. But then when you add on top of that the insult that people don't even believe you're hurting, it's quite a burden for them to bear.
Okay. There's a number of areas that we want to deal with this psychological, why it may cause psychological problems, i.e. the drug therapy and the ups and downs that may cause therein. Obviously the pain and suffering, and also the painful intercourse that may cause marital problems, and being unable to bear children, and any others that you may. So I just wanted you to talk about that a little bit.
All drugs that are used for treating endometriosis have side effects, and for instance, danazol, patients come in complaining of headaches, muscle cramps, joint aches. They complain of weight gain, decreased breast size, and that is a physical change in their body image that just is yet another straw on the camel's back, added to the pain and added to the fact that everybody ignores their pain. In terms of childbearing and infertility, that the desire to have a child is a very strong biological mandate in women, and it in essence defines their womanhood for many of them, and the inability to conceive is seen as a very cruel trick of nature upon them. They begin to look at other people who seem to get pregnant very easily with jealousy, and even if the woman conceives and has a miscarriage, that's viewed as a success because she has at least been pregnant, and yet some of these women will never have children. Their infertility, again, is not always due to endometriosis. Actually, several studies have shown that in women with endometriosis without a lot of adhesions, most of those people can get pregnant even without treating their disease.
The painful intercourse, have you prescribed psychiatric treatment for patients who have had their sexual lives totally interrupted and maybe their marriages?
No, I don't prescribe, I don't recommend psychiatric treatment for patients with endometriosis. They have a disease in their pelvis. The disease causes pain. There is no medicine that makes the disease go away. The disease needs to be removed surgically. If the disease is the cause of the pain and the painful intercourse, that pain will be gone. So what I prescribe to people who have psychological problems for this pain or that pain or painful intercourse is removal of their disease. The patients, when the disease is gone, do quite well in readjusting to a pain-free life, although many of them kind of go through life on tiptoes for several months or several years, kind of wondering whether each and every little twinge that they feel in their pelvis is going to be a redo of the same problem.
Okay, great. Sorry, Sue.
She's just burping,
Did you hear it all the way over there? So obviously you have found endo in teenagers, and we've discussed the mean age, and we've discussed the treatment. Do you want to talk a little bit about the drug treatment that is usually prescribed and different types of surgery?
The treatment of endometriosis falls into two main categories: medical treatment and surgical treatment. The medical treatment of the disease is based on faulty notions that were developed in the past. Early researchers on the disease looked at women who had large ovarian endometriomas, lots of scar tissue, obliterated cul-de-sacs, bowel disease, and noting that only about 40% of those patients had babies, they made the conclusion that, well, endometriosis causes infertility and pregnancy prevents endometriosis. Well, conclusions drawn from those early population of patients with severe disease can not necessarily be applied to the majority of patients who have lesser stages of disease. And yet, that's what's been tagging along over the years, this notion of infertility causing endometriosis, or endometriosis causing infertility, or pregnancy preventing or treating endometriosis. And yet, that did not stop people from trying to develop medical therapy to mimic the supposed beneficial effects of pregnancy. However, those effects were never proven by any biopsy studies. It was all a matter of seeing the patient during pregnancy, and if she were able to get pregnant, and observing, well, her pain is better during pregnancy, therefore the endometriosis must be going away. Pregnancy is good treatment of the disease. That represented a tremendous leap of faith, going from relief of symptoms temporarily to saying that pregnancy cures a disease, which is what people believe today. And the medical therapy that was developed to mimic pregnancy, therefore, was doomed to failure. Pregnancy didn't eliminate the disease in the first place, and since pregnancy does not eliminate the disease, medical therapy based on pregnancy does not eliminate the disease. The same can be said for pseudomenopausal therapy of endometriosis. It was observed that symptomatic endometriosis is less common in women after the menopause. The leap of faith was quickly made that, well, menopause is good treatment for endometriosis. Menopause makes endometriosis go away by some mysterious toxic effect of low estrogen levels. The foundation of pseudomenopausal therapy was on a faulty basis, and it wasn't until finally several biopsy studies were done after pseudomenopausal therapy that it was figured out that, well, no, danazol does not make endometriosis go away. The GnRH agonists do not make endometriosis go away. And the reason that no medical therapy makes endometriosis go away is because it was all based on faulty notions from the past that were never proven by any biopsy studies. And the other problem is that endometriosis has these low and varying hormone receptor populations compared to native endometrium, and so there's no reason to suspect that endometriosis should respond the way we expect it to respond to either the presence or absence of any hormone.
Or about the notion that it shrinks, though?
Medical therapy can cause the endometriosis lesions to become quiescent while the woman is on therapy. And because some of the reaction around the lesions consists of swelling and edema fluid, yes, people can get reduction in the size of the nodules during therapy. And that's good. I'm all for pain relief any way it is engendered, but reduction in size of nodules does not correlate with some toxic effect that eradicates the disease. And yet that's, again, what people have been assuming has been happening. As an illustration of the effects of the visual appearance of endometriosis on how medical therapy was developed, there was an influential study in 1975 in obstetrics and gynecology on danazol therapy. It was illustrated with many before and after photographs. And the after photographs showed what seemed to be visual improvement of disease, and this was thought to represent resolution or cure of disease. And yet the problem was that the pelvis was not biopsied in all these women after treatment to prove that the disease was gone. It was assumed that since the pelvis looked better, the disease was gone. They did take biopsies if they found lesions that they thought were typical endometriosis, and yes, they found endometriosis in those women. But they didn't biopsy all women, and so the notion escaped into the literature that danazol can cure endometriosis, and yet it was basically just a fundamental error of visualization.
So it looks like it's gone, but actually the pain could still be there.
The endometriosis, during therapy, the endometriosis can look better, and some people may think it looks like it's gone, and the pain can be better, and it's very tempting to make the conclusion that the disease and the pain have been eradicated forever, when actually that's not true.